I'm here with Dr. Todd Levine. Thank you very much for sitting down with me today. I really appreciate you taking the time.
Thanks for having me.
So obviously we're here to talk about, this grant, the NIH grant that you've received for synucleinopathy detection. I want to start, obviously the sign one test is kind of the bread and butter of this whole scenario, so to say.
Yes.
So just to start, could you offer a little background for the clinical community on how we got to this point with the test and sort of
Sure.
how it came to be?
Yep. And so it's really about 100 years in the making. So it's a long scientific process. So about 100 years ago, the first pathology was understood in terms of Parkinson's disease, and that was called the Lewy body, which was this inclusion inside the nerves in specific structures inside the brain. And that has been the sort of gold standard hallmark pathologic finding for the past 100 years. About 30 to 40 years ago, people began to uncover what was actually inside of this inclusion. And it turned out that one of the main proteins inside the Lewy body was a protein called synuclein. And that's a protein that all of us have. We actually still to this day don't understand the function of synuclein, but we know that we need it in order for our neurons to survive and to behave normally. Then people began to understand that there was two different forms of this synuclein. There was a normal form, and then there was a misfolded form. And the misfolded form of synuclein began to be the target for a lot of research into what we call the synucleinopathies. So Parkinson's disease, dementia with Lewy bodies, like Robin Williams passed away from, multiple system atrophy, which is a very devastating disease, and a rare disease called pure autonomic failure. But what all four of those diseases had in common was not just the presence of this protein misfolded in the brain, but it was actually the involvement of a part of the nervous system called the autonomic nervous system, which regulates things like heart rate, blood pressure, digestion, and all of those diseases had disruption of these autonomic nerves. And what became apparent was that if you looked inside of these autonomic nerves, you could see the same misfolded protein. And that discovery was about 10 years ago. And so we knew that you could look, for example, inside the neurons of the gut. But more importantly, for what we do, we realized that the autonomic nerves are also present in the skin. And so by taking a very small little skin biopsy that requires no stitches, we could look at these nerves and we could look at whether or not they contained this abnormal form of synuclein. And that's really what we have termed the SYN1 test, which is the first commercially available test that allows us to look for this abnormally folded form of the protein.
And then, so obviously you guys have conducted some work to get to this point. What is that literature sort of suggested about, particularly alpha-synuclein, its potential as a diagnostic biomarker, and how far do you think we can really take this thing?
So it seems to be a very specific and sensitive biomarker. And I actually like to say it's not so much a biomarker, but it's actually the pathology. So for example, if you did a breast biopsy and you saw the breast cancer cell, you wouldn't say that's the biomarker, you would say that's the disease. And so because we can now see the misfolded protein, it's actually more than a biomarker. It's actually visualizing something that shouldn't be there. Because of that, the sensitivity, meaning if you find that protein, how often that's associated with one of these four synucleinopathies is very high, probably approaching 98 or 99%. The sensitivity, meaning how often you might find it if you biopsied, let's say, 100 people with Parkinson's disease, that's been reported by many groups in Germany, in Italy, in Boston, and in our lab, to be about 95%. So we like to think that the sensitivity and specificity are both greater than 95%.
And then obviously early detection of disease has sort of been a push, that across medicine people have been pushing for. I'm curious, does this misfolded protein offer sort of any advantages in terms of earlier diagnosis compared to the typical diagnostic process for Parkinson?
Well, so it does. So the typical diagnostic process is basically to wait until a person has all the different features of Parkinson's disease. We understand now pretty clearly that the evolution of that process takes decades. So you can see people with what we now call pre-motor symptoms of Parkinson's disease. They lose their sense of smell, or they develop constipation because these autonomic nerves are not working well. They can develop sleep disorders, one in particular called REM behavior disorder. And these things might be present 10 or 20 years before the full clinical picture of Parkinson's disease evolves. Once that full clinical picture evolves, the amount of this protein that's deposited throughout their nervous system is overwhelming. And the likelihood that we could find a drug to just suck that all out is going to be very, very low. On the other hand, if we could detect these people 10 years before they develop those motor symptoms and think about developing drugs which can prevent the progression, we actually are optimistic that we can at some day prevent these diseases as opposed to just trying to reverse them, which would take a huge home run. We'd all love to have that. But realistically, the sooner that you can get to patients, the better. The other point is that very often early in the course of these diseases, the diagnosis is unclear, which leads doctors to order lots of tests and maybe try medications that have side effects that with no chance of working, and patients having to see many doctors and paying many copays, all because it's not a clear picture. So getting an earlier diagnosis allows a sense of closure, which can prevent a lot of unnecessary tests and medications and stress and anxiety for the patient as well.
Yeah, I think that really speaks to just how important the goal of prevention overall is. Considering not just, like you said, not just saving the patient from potentially having to deal with the disease, but all the things that sort of come along with having a disease like that. I'm curious, obviously this is commercially available, as you said. How has the test sort of been utilized commercially to this point? Is it as widespread as we'd like it to be? Is it, gaining steam rapidly? Where are we at with that?
So I would say the overall picture is gaining steam rapidly. So we have many academic centers throughout the country using the SIN1 test, many private doctors using the SIN1 test, and it's growing as word gets out. We're just beginning now to kind of market and to get the word out a little more diffusely across the country. I think the question of how it's being used right now is exactly how we would like to see it used. So, for example, if a patient walks into a doctor's office and they shuffle and they have a rest tremor, and the doctor says, I think that's Parkinson's, and they give them medication and the patient gets better, there's no need for a test. You've made the diagnosis, we're good, okay? Where it's really being used is in the diagnostic dilemmas. So that's where a person doesn't check off every box for a specific diagnosis, or perhaps it's early. And I had a patient just recently, a man in his 50s, for example, who had noticed for a few years he just couldn't keep up with his wife when they went shopping, and his legs felt stiffer. But he didn't have a rest tremor. He didn't have difficulty with a lot of the things that you would think of in Parkinson's. And he had gone through a very extensive evaluation because everybody was focused on the fact that his muscles didn't work. And it even ended up with him getting a muscle biopsy, a piece of muscle taken out, because I figured it had to be a disease of the muscles. And so after 3 years, he came to see me and thought, maybe this is very early Parkinson's. And we did the SIN1 test. It was abnormal, which confirmed that it was Parkinson's disease. Put him on medication, and within 2 weeks, he could go shopping with his wife, which he hadn't been able to do in 2 years. So it's those cases where you're just not sure which direction even to go in. It's the dementias where you're not sure, is this Alzheimer's disease or is it dementia with Lewy bodies? That's where I think we see physicians really using this test.
Yeah, and I mean, of course, that's a great clinical utility, and it sounds like, at least, especially in that one individual case, I mean, that's a life-changing, moment. Obviously, I alluded to earlier, you did this grant you received from the NIH recently. It's supposed to help fund the Synuclein-1 study.
Yes.
Synuclein-1 study. The play on words there. Could you offer a little background on that, sort of what you're aiming to assess, how many patients you want to enroll, and perhaps if you have a rough timeline, when we might expect results from that?
Sure. So we were very excited to get this grant. It's from the NIH. It's called an SBIR grant, really designed to promote scientific innovation. And so just to go through the process and to have their review committee choose us, I think is a good, speaks as it's a nice testament to the fact that there is a solid basis for this test already. And so, as I said, there's been 10 years of research to really support the sensitivity and specificity of this test, but we believe that we can actually advance that science. So it's not so much really a validation study. We, as I said, many centers across the world have already validated that this technique works. What we want to be able to do is say, what else can we learn from these biopsies? Not just whether the synuclein is present or not, but what about how much is present? What does that tell us about the disease process and the progression of the disease? How does that tie into the clinical picture? And so what we're doing is we're taking 500 patients with the 4 different diseases again. So Parkinson's disease, multiple system atrophy, dementia with Lewy bodies, and pure autonomic failure, as well as healthy controls. And in a blinded way, we're going to have clinical raters look at the information from their doctors. We're going to have people who don't know that clinical information look at the pathology, and then really try to put that together and say, how specific can we be about, for example, can we tell the difference between Parkinson's disease and multiple system atrophy? Those are closely related diseases, but carry very, very different prognoses. And so we'd like to be able to make that distinction from this, and using some algorithms and some computer aids. That's really the goal of this, is to push the science, not just from, yes, the abnormal protein is there, or no, the abnormal protein isn't there, but now what does that abnormal protein tell us? And to do that in by far the largest study ever done in the world, 500 patients, so that we can get this. And we have begun enrolling this month in December. It's slated to be a 2-year, 24-month study. So realistically, by the beginning of 2023, we would have the results.
Awesome. And then now, obviously, so we know over the next couple of years, looking, keep an eye out for those results. But in terms of just general use of this and the test itself, what should sort of the clinical community be aware of as we get closer to those results regarding this test, whether it's use in clinic or obviously, again, these results?
So I think the first is that, when faced with these diagnostic dilemmas, being uncertain about which way to go, now for the first time in any of these neurodegenerative diseases, having a test that a doctor can do in their office in a matter of 5 minutes, granted our side takes a few weeks, but, but their side about 5 minutes, then getting a very specific answer back. I think that's a big change. So we've never had a way to do that for dementias, like dementia with Lewy body. We've never had a way to do that for Parkinson's disease. So this is really kind of a game changer in the way doctors have to think, which is, if I see a patient, it's clear, I know what they have, we're good. But when I see that patient and I'm not sure, here's a test that can help me make my clinical decision-making better. And it's a very easy test to do that can be done in any office, in any world, any place in the country, and then shipped to our lab in Phoenix. So I think that's the first. And then I think, trying not to be too much of an optimist, but there are many drug companies in phase 2 and phase 3 trials of synuclein inhibitors. Again, the idea that this protein is as close to the beginning of the cause of these diseases as we can get is accepted across the scientific spectrum. There's no question this protein is the wrong protein. And so Biogen, for example, Denali, very large pharmaceutical companies are working to develop these synuclein inhibitors. So identifying your patient as having the abnormal form of synuclein also could then allow us to say to that patient, well, let's follow this, because it's possible within 2 years we might have a therapeutic agent. Yeah. Rather than sort of starting from scratch. So I'm hoping it's going to give people a bit more of a forward-thinking approach to these diseases, which for 100 or more years has basically been, you've got Parkinson's, there's nothing we can do, sorry. I think we're really on the verge of changing that.
Yeah, I mean, that would be absolutely, like you said, absolutely game changing, and yeah, certainly for a community that I guarantee would be extraordinarily grateful for it. Yeah. Before I let you go, is there anything else you want to add, or anything else that the clinical community should know, or your peers should know about this test, about the study, or just, the treatment of these patients in general?
Well, I think, these are very difficult diseases. So I've spent most of my career working in neurodegenerative diseases like Lou Gehrig's disease, which is a horrible disease. And very often I've said to people, one of the big challenges with Lou Gehrig's disease or Alzheimer's disease or Parkinson's disease is that we haven't had a way to follow the disease progression. And the parallel I give is HIV. So what allowed us to become so amazingly effective at preventing people from dying of HIV is that we can put people on a drug and then we can measure the viral load. We can say, did it drop the virus or not? And now people walk around completely healthy. You never cure their HIV, but their viral load is squashed to zero. It's just not something that's circulating. We've never had a way to do that for these neurodegenerative diseases. And I think one of the things we're so excited about is that for the first time, I could take a piece of skin from you today. I could look at it again in 6 months, 12 months, 18 months, 24 months, and I can see, am I getting rid of the synuclein? I mean, that is actually something that we can now do. It's not science fiction anymore. And I think that's really what we're going to have to be able to do is have the pharmaceutical companies develop a series of therapeutics, just like with HIV, right? When we had one HIV drug, everybody still died of HIV. Now we have, 30, 50 drugs, and we can just cycle through them and we can get that viral load down to zero. I think of these diseases in the same kind of parallel, which is the likelihood that one drug is going to cure Parkinson's or cure Alzheimer's is exceptionally low. But if we can have a cocktail of drugs that can stop the progression and we can identify the people soon enough, we can really prevent people ever dying from these diseases again, if we can do that.
Absolutely. And I mean, that would certainly be a welcome innovation.
Yes.
For the field and for those
It would
patients.
make neurology a lot more fun too.
Absolutely. Well, thank you very much for your time. This has been absolutely fantastic. And congratulations again on the grant. And I can't wait to see those results in a couple of years.
Super. Thanks so much.